So welcome everybody. My name is Winnie. I'm from Group Education Research, and we'll be starting the webinar pretty soon. So thank you for your patience. Now, this is the third installment in the seminar series, Humanity at the Heart of Healthcare, a series that's brought to you by my team, the Education Research team, over at Group Education in NHG. Now, this webinar series aims to highlight issues at the intersections of social science, research, the humanities, as well as clinical practice. First off, some housekeeping matters for our participants. We do have CME points for you. So please do stay around till the end of the webinar. The CME points application will be done together with the feedback form at the end, all right? The QR code that you do see here on this screen is for our coming session in November. So if you're interested to hear more, then do register here and we will keep you on our mailing list. Now, during the webinar, do post your comments and questions to our speaker and discussant using the Q&A button that you have at the bottom of your Zoom screen, and we will do our best to address these during the Q&A segment near the end of the webinar. Okay, so on to today's webinar. Today, we have two very familiar faces with us. We have as our speaker, Associate Professor Andy Ho. He's the head of the Department of Psychology from NTU. Okay, and our clinician discussant, Dr. 𝗪𝗻𝗀𝗀𝗀. Now, Mervyn is, of course, known to many of us in NHG, having been the 𝗪𝗁𝗪 department head for a number of years before his secondment as medical director of Dover Park Hospice. So, Mervyn, welcome to today's seminar and welcome to Andy as well. Thank you, both of you, for joining us. Mervyn also has an active research portfolio. I've seen his publications in quite a number of journals, and I've also talked to some of his collaborators over here at Homer and in his department as well. And his research portfolio focuses quite a lot on resilience and burnout in 𝗪𝗁𝗪 professionals. So I think, Mervyn, thank you for agreeing to be the discussant here at our webinar. I think you are the right person to have a conversation with Prof. Andy about the work in both your fields. And I think it'll be interesting to see how the work in both your fields can relate to each other. So maybe, Mervyn, you just start us off and tell us, why did you choose to focus your research on burnout and resilience in 𝗪𝗁𝗪? Over to you, Mervyn.
Okay, thanks so much, Winnie and team, for inviting myself and Andy to this very meaningful segment, and for giving us a chance to share about our own passion for this work as well on this topic. So maybe just to start us off, I'll just tell a story about how I got involved in this work as well. So it was probably more than 15 years ago, where I was still in training as a registrar, senior resident at the time. And I remember that was when I burned out myself. So there was a point in time where there was my family was young, my kids were young, and I remember answering referrals that were coming at 4:30 and 5, and being that rather obsessive geriatrician, palliative care physician, wanting to do a great job and settling the patient, the family. The primary team, of course, had gone home by that time. And I remember going home at about 7 something and having dinner, and then by that time my kids were asleep at 8. Yeah, so I went through a period like that where I didn't see my kids very much. I asked, and I was burning out. I was asking myself that, do I really want to continue to work like that? So at a point in time, I went through a period of self-reflection, and I decided to draw boundaries and make some changes to the way I worked, and to defer the non-urgent referrals to the next day, and to settle the urgent things that whenever I could, so that I could be home for my children. So that sparked my interest, and I think then after in 2013-14, together with my colleagues Alan Hum, Joseph Ong, and a few others in palliative care, we decided to do a nationwide study on burnout and palliative care. And lo and behold, we found that actually 33% of those who are doing palliative care are burnt out, according to Maslach burnout inventory. And this started our journey as well. At around the same time, I think Andy landed landed in the shores of Singapore. And we are thankful for that. And then we found out that at the point in time we were looking for interventions, right, that work. And we came across this work about mindfulness, compassionate art therapy, and we were like, wow, and the evidence behind that. So we actually invited Andy to our PEL-MED department during one of our department meetings, and he actually ran a session for us. And it was truly mind-blowing, and it helped us so much as a team. So today it really is my honor to introduce my colleague and my friend, Professor Andy Ho, who really he's got so many accolades. Among them, he's the head of psychology, associate professor of psychology at NTU. He is the past president Association for Deaf Education and Counseling, and he's on the board of directors for the very prestigious international work group on death, dying, and bereavement. He is a social scientist, a clinical innovator, and extremely passionate about the work that he does as well. 130 top-tier publications, 230 keynote plenaries, among his other accolades. So without further ado, I'll just hand the time over to Andy to share with us about his work. Yeah, so all yours, Andy. Yeah.
Thank you, Mervyn, for this very kind introduction, and thank you, Winnie and the team, for having me to share some of the work we've done in NTU with the rest of the NHG colleagues today. Mervyn, your story that you shared, I can completely empathize with that, because there has been a period of time. Right now, actually, my son is only 3.5, and I sometimes barely get to see him for 15 minutes a day because I'm often at the office. So that's a good reminder for me to take care of myself more. It's quite difficult to be in the profession that we're in, and while at the same time we know that self-care is so crucial, we lapse in our thinking. We just focus so much on our patient and the people that we're working with. We lose sight of what's really important. That's us. And so today I want to spend this time and share with you some of the work that we've been doing in Singapore, finding ways and trying to figure out what we can do to support healthcare workers and social care workers like yourself who are immersed in the field of medicine and palliative care, and what can we do to elevate your ability to engage in more self-kindness, self-loving behavior, so that you are more rejuvenated, you are more able to look after the patient that you're working with. I think Rosalind Carter's have a really, really important quote. She says that there's only 4 kinds of people in the world: those who have been caregivers, those who are currently caregivers, those who will be caregivers, and those who will need a caregiver. And every one of us will eventually fall into one of these roles. And all of us now are currently caregivers, either for our patients, for our family members, and for the people that we love. To be a caregiver, it's extremely rewarding, and we all know that. But at the same time, it can also be extremely physically, emotionally, and psychologically taxing. And this is because health and mental health care professionals are often called upon to be the strongest person in the room. They need to be able to have the solution. They need to be able to have competence. Yet at the same time, they're also dealing with a lot of stressors, a lot of demands, and getting pulled in all different directions. Yet there's really no training in our curriculum, in our undergraduate studies, in our master studies, how to look after ourselves and how to deal with all those stressors. And for those of us who fail to cope with these stress are sometimes deemed weak and lacking in character and personal strength. And because of that, many of us are fearful of vulnerability. There's a big research that I conducted a few years ago looking at end-of-life care professional in Singapore. I interviewed now 107 of them, asking them, what's the challenges that you face? What are some of the experiences that you have in your process of caring for someone who's facing the end of life? And many of them told us about the stress that they're facing. Many of them told us about, I want to be able to have the support that I need, yet I'm afraid of seeking it. There are many support provided by institution, but once you do seek it, there could be ramification that people are often afraid of, such as this medical social worker who told me that, you can go and talk to an institutional counselor, but you're seen as weak, not competent. I don't know, whatever I share with them comes back to disadvantage me in the future. So this ethos and this culture of fear of vulnerability have really made people becoming much more unwilling to share about their experiences. They sweep their anxiety, they sweep the pain under the rug, and they don't deal with it and they don't address it properly. And for those of us who are working in end-of-life bereavement and hospice care, the stressor are even more prominent. The reason for this is because medicine, even in the 21st century, is still very heavily focused on a curation focus rather than palliation. And because of that, death and dying is often seen as a taboo as well as a failure to medical professional. If you look at the research across culture, you'll find that across the clinical population, patient population, and professional medical worker, most of the time it's identified that the physicians, the clinicians, and the nurses are the ones that are most afraid of death, even more so than those who are actually dying. And a lot of this have to do with the lack of end-of-life care training for these medical professionals while they're preparing for the career. And those who lack the capacity to cope with the emotionality of death often withdraw themselves from the bedside of dying patient. And many suffer from trauma and unresolved grief. One of the director physicians that I talked to told me that I felt a great loss. I feel really sad because when you keep taking care of the patient, you develop quite a good relationship with them. So when they pass away, you feel like one of your relatives and one of your loved ones have passed away too. And all of this combined create the perfect storm for burnout. And I think the word burnout has been around for a good number of years, become very popular, but we do need a clear definition of what burnout is. It is defined as the state of emotional, physical, and mental exhaustion caused by excessive, prolonged stress. It occurs when you feel overwhelmed, emotionally drained, and unable to meet constant demand. And as Mervyn has alluded to earlier, many of us in the healthcare industry are dealing with burnout. One study was done before the pandemic, just before the pandemic, identified that 44% of physicians in the US and 1 out of 3 nurses in the US suffer from high level of burnout. And there are numerous reasons for them to feel burned out. One of them is student debt. Another one is to having to deal with electronic healthcare workers, which all of us have to deal with. And they feel like being asked and tasked to do these work remove them from doing the work that they really want to do. Many of them suffer from the lack of sleep. They feel like they're out of control. And all of these factors can lead to chronic stress and burned out indeed. And there is another study in the US that was done in the midst of the pandemic, and the pandemic add more fuel to this fire, where burnout has become a real global medical crisis. Many people are afraid of getting COVID. They're afraid of the state of the world. They are working longer hours. And because of all of this, nearly half the workforce have considered quitting, changing careers, or even retiring. And we've seen this in Singapore. In the midst of COVID, in the past 3 years, there has been a lot of turnover in the healthcare industry. We spent years training doctors and nurses and social workers, but 2 years into the job, they have no resources to support themselves and they leave the industry. And that not only is a travesty, it's also a great drain on our educational resources. The problem is extreme. More than half of the people that was interviewed in this study reported that the mental health was worse, progressively worse, a year-by-year basis. Half of them cried at work, 12% seeking psychotherapy, 1 in 3 of them feel like they made a mistake at work, 32% of them have less than 4 hours of sleep, and 48% admitted to feeling at least mildly burned out. And I think many of us in the audience today could potentially identify with some of these symptoms that our Western counterpart has been experiencing. So far, we've talked about stress as mostly as a psychological, emotional ordeal, but it's really not. According to numerous definitions, stress is understood as the bodily response to threat and demands that's external to us. So we need to understand this from a biological perspective. It's not just emotional, it's not just psychological, but it's physiological. So if you look at our human body, it comprises of a number of systems that help us do the things that we do every single day. And one of the biggest systems that is involved is the nervous system. Within the nervous system, there's a central nervous system that comprises of the brain and the spinal cord that help us remember things, process information, and to get us to places that we need to go. The other less known nervous system is the peripheral nervous system, and this deals with our voluntary muscle and involuntary muscle. So voluntary muscle would be my finger, my hand, my arms, my neck. When I think about anything to move from one place to another, my legs lift up and start walking. Those are the voluntary muscle. The involuntary muscles are the ones that's inside our body, such as our chest, our lungs, our gut, our stomach, our bladder, our liver. All of these things are involuntary because we don't have to think about it for it to work. We don't have to think about, hey, let's breathe, so breathe. No, it just happens automatically. So that is called the automatic nervous system, the involuntary muscle. And within the automatic nervous system, there's 2 smaller systems at play. One is called a sympathetic nervous system that helps us to mobilize energy and expand our energy in the case that we're dealing with an external stressor. The other end of the spectrum would be the parasympathetic system that helps us to conserve energy, allow us to rest and digest and rejuvenate in case there is other demand calling upon us in the future. These two systems often need to work in balance with one another. The sympathetic nervous system help us to engage in fight or flight mode, whereas in the parasympathetic system help us to engage in rest and digest mode. So when we're activated, when we're dealing with a stressor, when we see a car running down a highway approaching us, our pupil dilates, we don't salivate, we're perspiring, we have accelerated heart rate, we don't feel hungry anymore, we don't feel aroused, we just need to have all of the adrenaline, the power, the cortisol in our body to help us deal with this threat, whether we fight it or we run away from it. The other system is that when we're not at a fight or flight mode, we actually get to rest. We feel hunger. We are able to salivate. We slower our respiration. Our heartbeat slows down, and it gives us the chance to recuperate. These two systems need to work in sync with one another, and that's called the status of homeostasis. An operational system that allows us to maintain optimal functioning. When we're in balance, it helps us to regulate our body temperature, it helps us to regulate our body acidity level, our oxygen content, and all the things that makes us healthy and well. And when our body is not in a state of balance, when there is external demands, such as our boss calling us at 2 a.m. in the morning, or when someone is sending us an email when we're on annual leave and expect us to reply in half an hour's time, then we're no longer in homeostasis state. We go into an allostatic state. That is when our body and our mind and our brain is giving us the energy, the adrenaline to deal with that external stressor. The allostatic state is a normal state. It helps us to deal with the environmental changes that's happening around us. It helps us to maintain stability when stress occurs. It's only though, however, it's meant for short-term activation. But when we are activating it for the long haul, then it can lead to biological duress. For example, in the life that we live in nowadays, although yes, we have sort of an office hour from 9 to 5 or sometimes from 8 to 5 or whatever it may be, although we are supposedly working during those hours, but our mind is never resting. Once we get off work, our mind is still thinking about the patient that requires our support. Our mind is still thinking about the patient that requires a surgery tomorrow, and I'm involved in that. Our mind may still be thinking about the family member who is shouting at me in the hallway because I didn't fulfill their demand. Our mind is still thinking about the 10 reports, 20 papers, and 50 consultations I have to do tomorrow. So our mind is not at rest, even though our body seemingly to be at rest. And that means that our body is never in the state of balance. Our body is never in homeostasis. It's always in the state of allostasis. And that could lead to something called allostatic load. Allostatic load is really the wear and tear in the body, which accumulate as we are exposed to repeated chronic stress. And we think about the way that we live our life. We wake up in the morning, the first thing that we reach for is not our partner and give them a loving kiss. We reach for our phone and check for our messages and WhatsApp and our email. And our day begins there. And it does not end until the final moment we close our eyes, and that's when we put our phone down. And for some of us who's really stressed, the moment that we close our eyes, we start to ruminate about the day. We ruminate about the next day or the day that has gone before, and we never really rest. And when that occurs, our stressor will never stop. When it does not stop, that means that our sympathetic nervous system is constantly flipped on, always and all the time. And this would result in something called allostatic load. For the short term, it would have detrimental, simple physical symptoms, such as experiencing headaches, migraines, anxiety, apathy, anger, skin irritation, stomach problem, trouble concentrating, fatigue, and decreased sex drive. Now, these are some bodily symptoms when our body is telling us, hey, you gotta stop. These are red flags, and you're gonna stop and recuperate and rest. But we often see these as just minor issue, and we don't pay attention to it. We just take medication to cope with our pain and just let it slide. And when we do that, then all of these stressors, all of these stress hormones, cortisol, epinephrine, and norepinephrine will constantly be over-reproduced. It will stay in our body, causing a weakening of our immune system in the long haul, inducing illness such as stroke, hypertension, cardiovascular disease, and even more recent study using functional MRI have found that an allostatic overload can lead to reduction in brain volume, gray matter density, white matter integrity, and general cognitive decline. So this is not a small issue. Stress is not something that we can simply overlook and brush under the rug. We must address this. And perhaps one of the most detrimental outcome that's external to us is workplace error. According to a recent study in 2018 in the US, with 6,386 surgeons, 10.5% reported having made a major medical error in the past 3 months. And the reason for them to make these errors are burnt out specifically. The Dalai Lama says that for those of us who are undergoing great suffering, if you feel burnt out is settling in, if you feel demoralized and exhausted, it is best for everyone's sake to withdraw and restore yourself. Because if you're really burnt out and you're angry and you're frustrated and you wake up in the morning, you don't like what you see, you drag yourself to work, walk into the office, don't like your colleagues, don't like your boss, don't like your patient, don't like your family caregiver, then you're really no good to anybody. And I think that's why we need to have really important avenue and capacity and time for self-care. You know, now we all traveling after COVID, and every time we get on the airplane, we know that when the oxygen masks start falling off from the ceiling, the first thing we're asked to do is to put on the mask first, because once we passed out, we're no good to anybody. We're no good to the children, we're no good for elderly, we're no good for anyone. So we must look after ourselves first in order for us to look after someone else. And I believe that this is not a luxury, it's not an option. This is a necessity, because if you look at the first page of your professional code of conduct, whether you're a physician, whether you are a nurse, whether you're a medical social worker or psychologist, it will tell you a number of things. As a human service professional, my job is to ensure beneficence, that I'm bringing benefits to the people that I'm serving. I must engage practice that is non-beneficent. That means that I must cause no harm. I must practice my craft with veracity. I must be informed and evidence-based. I must practice my craft with integrity and compassion. But when you're so consumed with stress, when you're so frustrated and you don't want to be what you're doing, and you're undermining your own profession, when you become sarcastic about the work that you do, then you will not be able to meet the basic requirement of your ethical standard as a human service professional. So self-care to me, and I think to all of you, cannot simply be a luxury. It needs to be a necessity for you to do your job competently and well. And this brings us to mindful compassion art-based therapy. There are many different ways for us to engage in self-care, but one of the ways that we created organically and locally in Singapore is this intervention. And I must tell you a little story about this. As Mervyn have shared with you, I'm not Singaporean. I came to the shore of Singapore, not through a boat and plane, about 9 years ago. And the reason that I'm here is because of love. My then girlfriend, then fiance, and now wife is a local born and bred Singaporean Peranakan lady, which is an angel to me. And she's also an angel to many families because she used to work as a pediatric palliative care social worker. She works with dying children. And that's the reason we met. We met at the Deaf and Dying Conference, and then we found love, and now I'm here. When we're in a long distance relationship, everything is wonderful because you only get the window of an hour of a day to talk to each other through a screen, and you present the best version of yourself to each other, which is wonderful. But as I begin to fall deeply in love with her, I decided to move mountain and sea to come to Singapore to be with her. And so once I got here and started living together, I realized that yes, she's still the angel that I know, but she is dealing with a great deal of stress. You know, she could be on call. She would be on call every single hour of the day. She could be in the middle of the movie, she could be in the middle of the dinner, and someone calls her, she would be in the patient's home in half an hour. And she would be holding the hands of a dying child and watching him take his last breath while also comforting the parent. And that could be very traumatic for her and people like her. So when I see her experiencing all of these exhaustion, I start asking myself, what can I do to support her and people like her better? I have the luxury to learn under the wings of many great mindfulness practitioners. I also have the luxury to work with numerous art therapists when I was at the University of Hong Kong. And then I start thinking, hey, maybe these two modalities can work quite well together. Mindfulness self-compassion is really about reflecting and understanding who you are and gaining self-discovery. And art therapy is really about being able to tell your story, express yourself, and that could lead to healing. What if I integrate the expressive power of art therapy as well as the reflective power of meditation? Then these two things can go hand in hand to provide a platform, a structure, intervention to provide support for local practitioner in end of life. So as the name would suggest, mindful compassion art therapy comprises of the three major elements. The first one is compassion. Compassion is the idea that I am aware of the suffering of other people with the concern to alleviate that suffering. It is a concept that is interwoven into all major religions in the world, but if you remove all the religious connotation, this is at its core what it means. I must first distinguish the two words between empathy and compassion because they're often used interchangeably in the literature, but they're different things. Empathy, according to Gilbert and Choden, is a heightened focused awareness of the experience of another, of someone to be understood. So basically stepping to the shoe of another, seeing the world through the eyes and understand what they're feeling and feeling what they're feeling. That's empathy. But by itself does not lead to compassion because a serial killer or psychopath can very much empathize with their victim, feel their pain, enjoy the pain, and induce more pain. So empathy is a construct does not necessarily lead to compassion. Compassion required us to acknowledge and become aware that suffering is happening with the innate desire to alleviate it, according to Strauss. So if you look at these two constructs, then empathy, yes, is an integral part of compassion, but empathy by itself does not lead to compassion. Compassion involves our empathetic capacity to recognize suffering and then do something about it. Whether it is to stay with suffering, just to witness it from happening, that is a compassionate act, or be motivated to alleviate suffering, or to be able to engage in compassionate action. I also want to be able to spend just a minute of time to tell you, biologically and neuropathologically, what does it look like for someone to be empathetic? When we put someone under an MRI and we ask them to feel and be empathetic to what someone else is suffering, what lights up is all the mirror neurons in our brain. We are activating the interior cingulate cortex in the very primitive brain, we'll call it, near the amygdala. And this allows to mirror exactly what the other person is feeling, and therefore we can feel for them. And when we do this, oftentimes we're not able to extract ourselves from those emotions. We over-identify ourselves, our patient, and the people that we're caring for, and therefore leading to empathy, distress, fatigue. This is a new term because before this term it became something, what was often prescribed in the literature is something called compassion fatigue, which now has been completely debunked. So if you don't take anything away from me today, the one thing that I really want you to take away is that there's no such thing as compassion fatigue. Because once we put someone under the MRI and ask them to imagine that you are being compassionate to someone, you're feeling for them and you want to be able to alleviate their suffering, what actually happens to the brain is the activation of orbital frontal cortex, the ventral striatum that is in the more advanced brain when the prefrontal cortex. And this process actually triggers the cognitive reward system that allows the release of oxytocin into our body, the love hormones. And what that means is the more compassionate that you are, the more oxytocin is released into your body, the better that you feel. Then compassion can never ever fatigue. It can only build resilient. And that is a myth that we need to debunk from this point forth. Okay, so if compassion is so powerful, what element does it contain? Number one, it contains or requires us to be mindful. Because we're walking down the street and we're looking at our phone and we don't even see anything. Someone could be bleeding because they trip and we don't notice it. So in order for us to be compassionate, we must be in the here now and be aware of what's happening. Be aware of suffering has occurred without judgment and without aversion. That's important because oftentimes when we see suffering happening, we often run away from it because it doesn't make us feel good. But to be mindful requires us to be here in the now and not running away from difficult emotion. When we can do that, then we see that something is wrong and it activates our innate pro-social caring motivational system. As a human species, we're genetically and biologically ingrained to be kind. We want our species to survive, if you look at evolutionary psychology. And therefore, once we're mindful, we're aware that suffering is there, we want to be able to treat ourselves and others with kindness to alleviate and soothe that pain. And the more that we do that, we experience something called common humanity, that your pain and my pain, although it happens in different contexts, are not so different. We are, after all, interconnected and interdependent. Our experiences is part of a larger human collective. We are no longer alone in our pain, and we feel much more connected to the people that we're serving. And this then adds to the upward spiral of more awareness, more kindness, more presence, and more compassionate action. We often think about compassion as an outward experience, but it's not only that. It can also be an inward experience. By paying attention to ourselves and being able to understand that we too suffer, we too have pain, we have vulnerability, we have limitation, that means we're opening ourselves to these negative emotions. Rather than running away from them, we're now looking at it, understanding it, addressing it. And once we understand why we're feeling this way, we can have the great capacity to provide ourselves with comfort. Self-compassion, through 20 years of research, has been found to be associated with intrinsic motivation, curiosity, personal growth, healing, and most important of all, less afraid of failure. Because if you know that if I fail and I can do something to make myself feel better, then what's the best case? What's the worst case scenario, right? So self-compassion provide this protective mechanism for us to explore the world with greater curiosity and rigor. Self-compassion, the good thing about it is always available. It doesn't rely on other people to give it to you. You can give it to yourself. It's a skill that can be taught through contemplative practices such as mindfulness. Mindfulness is simply paying attention to the here and now without judgment and resistance. And although that seems easy enough, but this illustration, which is a very common and popular illustration, can tell you exactly what a mind of a human being look like, which is often filled with rubbish and irrational thoughts, worries about the future, regrets about the past, and things that we cannot change. Whereas if you have a dog or animal or pet at home, if you play with them, observe them long enough, you realize that their mind is filled with clarity. All they see is what's in front of them, and they're really living in the moment. But a human being, while I'm physically here, our mind is wandering somewhere else. And when our mind is not fully here, we become out of touch. We see without knowing, we hear without listening. And we do this all the time. You know, our spouse tells us one thing, but we never remember it because we're not fully here. We eat without tasting. You know, Singaporeans love our food, but we start shoving food down our throat and start inhaling our food without tasting them. That's a great travesty of life. We touch without feeling, we speak without connecting. And on Thanksgiving Day, in this little comic, while everybody's at home, they're on a device. It's only the dog that realize how wonderful it is to have everyone home again. We can break down mindfulness to even smaller components. The first step of mindfulness is to be here at the present moment, pay attention. The second element is to relate to the experience without judgment and resistance. So being with the emotion without judging it, without running away from it. And the third idea is that I can understand the difference between the experience and the people who are experiencing the experience with the desire to alleviate suffering. Once I notice that suffering is there, I want to be able to help. And that's where compassion comes into play. The more we do this, the more we begin to realize that there are things that I can do, but yet at the same time, there's also my limitation. I can also understand that, yes, I'm here to help, but I cannot be the complete solution to anyone's problem, realizing our own strength and weaknesses, leading to wisdom. These four things accumulate and build on each other, and the more you practice it, the better you become. And for me to be mindful, and for Epstein as well, is not really, again, an option. It is a necessity, because if we're mindful and aware and paying attention, we can often maintain a stance of clarity, to be non-reactive. If a patient presses a button, we don't fight back. We pause, we think, we feel, we really cognitively process what's happening here. What's making me so angry? What's the reason for him to feel so much anger in him? Then I can perhaps listen differently. I can attend to someone's need authentically. I can also maintain a degree of humility, discover what serves best in the situation, let go of our ego, our self-interest, and engage in courageous action that preserve integrity. And we need a lot more of that in the world that we live in today. So mindfulness and compassion are great, but they are avenues and mechanisms for us to engage in reflection, introspection, and self-discovery. What about sharing our experiences? Sharing our experiences allow us to become creative, and it allow us to share our emotions in a deeper sense. And the reason for this is because a lot of the things that we feel are so profoundly emotional and difficult that we often don't have the words to describe them. But when we can actually see our emotion, change something intangible into something that's tangible. For example, my emotions of sadness, I don't know how to describe it, but I can envision it. I can think of what's the color and what's the shape of my anger, and then try to craft it into a painting or a sketch. I can now see it. I can describe it a lot better. This type of art making is really about creativity. What distinguishes human beings from other type of living species that we have the power to create something out of nothing. We're able to bend ideas and integrate things together. We can see things in new ways. And the way that we can practice creativity, it helps us to feel alive. When we're able to express ourselves through creative means such as the arts, enable us to describe something that is so indescribable. by seeing and touching and sensing our emotions, something that's more tangible, we're much more able to make sense of what's actually happening. When we express ourselves, when we tell our story, every time we tell it, we engage in the process of narrative identity processing. We tell our story, we understand who we are deeper, and we can lead to a process of healing and also relational building. If you think about our human condition, we are relational beings. And by using art as a means to connect, we can tell our story, allow our story to be portrayed, allow others to understand us through imagery. We can use art as a form of encounter, to engage in dialogue, to balance judgment. We can use art and creativity as a form of community building, to foster creativity and enhance tolerance, and also engage in reflection. The more that we can use art to engage in communication and to build relationship, the more we can cultivate something what Michael Bloomberg would call the 𝗖𝗿𝗲𝗏 relationship, that we are interconnected, that we're not single individual that was born out of a rock. So once you integrate all these three things together, then we have mindful compassion art-based therapy, really a new paradigm for collective self-care and resilience building. So I will tell you a bit more about MCAT in a bit, but as a social scientist, we would never just create something and think that it works. We must test it and put it to an assessment. So we conducted a gold standard and randomized control trial. We recruited 56 frontline end-of-life care professional from 𝗥𝗂𝗃𝗀𝗃 hospice care, and we randomized them into two groups, the intervention group and the control group, and we assessed them at 3 different time points. At baseline, when none of them received anything, at T2, when the intervention group received intervention and control group received nothing, then we assess them again, so we can compare and contrast if there's any positive change that occur, and if did, it must be due to MCAT. And after the T2 assessment is completed, we provided the intervention for the control group, so everybody benefits, and we measure them the 3rd time. And what this allows us to do is then to assess for the intervention group, once the 6 week is over, it's a 6 week intervention, and if they receive or experience any positive change, could these change be long lasting? And we measure them on a number of scales, including burnout, resilience, mindfulness, compassion, deaf attitude, and quality of life. And these are the demographics of the participants, and there's really no significant differences between them. As a 6 week intervention, every week we meet for 3 hours, and the 3 hours goes like this. Starting with a 5-minute check-in, a 20-minute mindfulness meditation with guided imagery, and then a 50-minute art making session and a short break. Come back for mindful breathing activity, engage in the second part activity, which is to do a response art, which is to do some reflective writing or group mural, engage in small group discussion, then large group discussion, then we have a mindful breathing and a checkout. And a 3 hours seems like a long time, but it does go by very quickly when people are so immersed and engaged in the work that they do. And as I mentioned earlier, MCAT is a 6 week intervention. So what do we do each week? Each week we have a different meditation and a different theme for that week's topic. So for week 1, we start with something very simple. Self-care. We started with a meditation on affectionate breathing, focusing on breath and allow our breath to bring us a degree of centeredness, nourishment, and peace. And using guided imagery, asking participants to imagine a time when you have been very kind to yourself. And what did that look like? What did that feel like? Is there a symbol, is there an image that comes to your mind? And then we ask them to create a mandala, a spiritual circle of self-care. And this is one art piece that was done by one of the social workers. And she wrote that we need to live not in the past nor the future, but in the present. In the present is self-care for her. In week 2, we go a bit deeper to talk about stress management. And this week, we started with a compassionate body scan, using our breath and our attention to scan for every part of our body to see which part of it is the most painful, most tense. And then we asked them to visualize what the tension and stress looks like, and then create an art piece from it. So this, on the left-hand side of the screen, is one of the art pieces that was done by one of the social workers. To her, her stress is like an active volcano with lava coming out of it, can explode at any minute. After the break, we asked them to come back to look at the art piece and say, hey, you've created this stress. What can you do to make it more acceptable to you? And so this person created an illustrious forest, and she wrote, stress may not be a bad thing. It can bring out the brilliance in people. And that symbolic change of what stress is profoundly life-changing for her. In week 3, we talk about clinical experiences. So we started with loving kindness meditation. We asked participants to engage in a reflection about a situation or encounter with a patient that they have been very successful. They have made good progress, and they feel like they have been a good part of this care journey. And so we asked them to create a piece of art. And for this social worker, she wrote that journeys for patients are long and waving. There are many up and downs. Many patients struggle to find peace and hope, and I wish them safe and calm. In week 4, we go even further to talk about challenging patient interaction. when things didn't really work, and how did that feel like? How did that struggle look like? This is a particularly interesting and important sketch. This was done by one of the physicians that was in the group. And I still remember him in week 1, when we had a large group sharing. There was a nurse across the circle that was sharing about her experience of our patient, and she was emotional, she was crying. And this physician was so uncomfortable with emotions, he started lowering his head, crossing his arm, crossing his legs, and then finally to flick off his pants for 5 minutes. He was uncomfortable, and I know that it was uncomfortable for him, and I allow him to stay in the group and encourage him to do more. And by week 4, this is what he did. He had a sketch of 2 hands holding onto each other, and he wrote that while I want to hold onto the hands of the vulnerable, I also recognize that I myself am a vulnerable being who needs love and support. The change in perspective and the willingness to support himself and others from week 1 to week 4 is profound. In week 5, only then we talk about grief. We have the meditation on the reflection of impermanence, and then we ask participants to create a symbol of grief, an art piece of grief. And this is the image that we are looking from the top-down angle as a person navigating through a Red Sea. And this particular clinician wrote that when all is drowning and sinking in adversity, we need to be still and persevere, to embrace the trapping moves and see them as a dance of life. In week 6, we focus on meaning. So after having gone through the previous 5 weeks, what does it all mean to you? Having gone through medical school, having gone through nursing school, and having been in your profession for so long, what does it all mean? And so we asked them to reflect on that and create a mandala. We started with mandala, we closed with mandala, and at the end of the session, we asked participants to have a gallery walk in the room to identify art pieces that are similar to theirs in terms of color, composition, and theme, and put small murals together, a collection of art pieces. And then we asked them to tell a story about this mural that you have created. And this is one of the murals, and they wrote that we're often fixated in looking at things at the horizon level, but what we see is not all that's there. Deep down in the blue sea lies beautiful fishes, high up in the heavens, there's a beautiful paradise. It is up to you to find meaning in it all. And at the end of the closing, we put everyone's mandala together from start to finish to tell a cohesive story. And this is one of the major murals that was conducted or created, and it's called The Seasons of Life. These participants put a very short poem, and they wrote, "Let the fallen leaves be the nourishment for next spring, together in this endless journey of life." So graphically and conceptually and theoretically, it sounds great, but what about the data? What about the statistics? So we ran a number of analyses to compare the 2 groups. We also looked at the significance level and also looked at effect size, how effective is this intervention in inducing change. And so what we discovered is when compared the experimental group with the wait-list control group, those who undergone the intervention experienced significant enhancement of quality of life compared to those who didn't in time 1 and time 2, and also experienced significant level of enhancement in resilience as well. They also experience significant level of mindfulness ability, and also the ability to be non-reactive to negative emotion, which is also very important. So the 2 groups, when we compare them, there are significant and profound change that has occurred. When we follow the intervention group for another 6 weeks, what we discovered is that for those who went through the intervention and then 6 weeks later, their level of burnt out and mental exhaustion continued to decrease continuously. 6 weeks later, receiving nothing, their level of mental exhaustion continued to get at a lower rate. And we have a high to medium to a high effect size of 0.667, which is tripling that of what usually psychotherapy have, which is 0.22, and also the effect size of pharmaceutical agent, antidepressant for the treatment of depression, which according to the New England Journal of Medicine, it's only at 0.26. Okay, so we also experienced and found that people who experience MCAT experience significant level of resilience enhancement and continuous enhancement in quality of life. 6 weeks after the intervention was over, effect size 0.778. We also found they experienced enhanced level of mindfulness, their ability to describe their emotion and observe their emotion, effect size 0.515. They were able to be non-judgmental and to be non-reactive to negative emotion. So they can pause and think and find what serves best in this situation. They're able to engage in continuously and sustainable self-compassion practices, as well as seeing their experiences as something of a larger whole, beginning to see there's interconnection between themselves and the patient and the people that they work with. They're able to be mindful, to not over-identified, effect size continue to be very high. We also asked participants after they completed MCAT what they thought about the intervention. And many of them tell us, MCAT helped them to reduce burnt out. As one of the social workers says, that you're expected to fill a lot of roles and a lot of shoes. And that's why it's so important to put yourself first, to care for yourself first. A physician says that MCAT helped him to foster mindful living. Our work is filled with strong emotions. Sometimes we really have to pause and just breathe in peace, calmness, and awareness before we can perform our task again. A nurse says that MCAT nurtured her compassion. When I focus on breathing through my nose, it made me think about my patient who was really struggling for a breath. I came to appreciate the simple gift of breathing. A social worker stated that MCAT cultivated a sustained resilience for her. I wanted to be able to embrace my stress instead of fixing my stress. I feel now I can actually cope with stress a lot better. A nurse says that it enhances her quality of life through changing her perspective and reframing how she sees things in life. She said, another thing that I see in this picture is happiness. Happiness can be very simple. Happiness is what you're content with. So with this study that was done a few years ago, we went on and did a second study with patients, with family caregivers of patients with dementia, people with dementia. And we started the study in the beginning of the pandemic. And so we couldn't do anything physically in person. And we translated the entire in-person intervention into a virtual platform offered through Zoom. And we condensed the 6-week intervention into a 4-week intervention from 18 hours to 10 hours. And what we discovered, we finished the study and we're publishing the paper now, is that even through a virtual platform and a reduced dosage of intervention hours, we are able to generate the same exact type of intervention outcome, and they are also sustainable. And so this really goes to show that MCAT can be changed and adapt to different population groups. It can be done in person, it can be done through virtual means. It enhances the scalability as well as the accessibility of this intervention for other people who may be interested in it. I do offer an MCAT workshop every single year through the Pell Healthcare Center for Excellence in Research and Education. It's a 2-day intensive, immersive experiential workshop. I'm also open to offer training for individual organizations and departments, and you're more than welcome to connect with me. The last 2 things I want to share with you before I end the presentation is that recently I published a book with a very good colleague and friend of mine, Dr. Darcy Harris from King's College. It's called Compassion-Based Approaches in Loss and Grief. And this book has more than 23 different chapters and 50 different authors to talk about the ways you can use compassion in supporting patients at the end of life and supporting family members who are going through bereavement and all different types of human tragedy. So if you're interested, do get a copy of it. And this does cost money. The second thing that I want to offer to you is completely free. I have developed a podcast for the Compassionate Thanatologist. If you don't know what thanatology is, in very short, thanatology is the study of death, dying, and bereavement, and a thanatologist is someone who does that. And so through this podcast, I'm providing everyone with guided meditation on self-care, personal reflection on moving with loss and grief, as well as expert interview on our experience in supporting those who are facing grief, loss, and bereavement. It's available on podcasts, it's available on Spotify, it's completely free. Go and search for the Compassionate Thanatologist, and I hope this will be a resource for you and the people that you work with, as well as the people that you're caring for. Finally, I strongly believe that the quality of care of patient is only as good as the quality of health of the caregiver. So for all of us here, 138 of you, please, please, please look after yourself. Thank you.
Wow. Thanks, Andy. I think that was fantastic, really fantastic. I really like what you shared, and you compared and contrasted empathy and compassion. And that with compassion, it's that additional desire to relieve it rather than just being empathetic about it. I was particularly intrigued about your neurobiology slides as well. And and thanks for updating us about empathy distress fatigue and having overtaken the common term of compassion fatigue. It was just thrown all over previously. Okay. We probably would want to just check in on the Compassionate Thanatology podcast as well. I didn't know you had that up too. So okay, I think we'll just open the time to questions. There are 4 questions that have come through. Maybe I'll just pick 1 or 2 and to ask Andy here. And Okay, this is a question. Hi, Prof. Andy, it's great to hear about your research. On a practical basis, how do we translate your work into a healthcare environment at a sustainable level?
That's a great question. I think there's multiple layers and multiple facets that we need to be able to work with. Number one is the organization and institution have to recognize that their employees are valuable assets, that we need to look after our physician, we need to look after our nurses and social workers and outline care professional, and give them the support and the time and the resources to engage in self-care practices. Secondly, if you have something like MCAT that is standardized, that's been empirically tested, and is shown to be robustly effective, then we can potentially integrate this into our everyday clinical practice as part of a support services that's provided for the healthcare team. So for example, I know, and you would know, that a social worker would see a supervisor once every 2 weeks or once every month to talk about their experiences, to really have the support that they required. But nurses and clinicians often don't have this support or this someone to talk to. And so we can actually integrate this into a regular schedule of a medical professional, healthcare professional line of work, then it would be tremendously helpful. And I know that MCAT is a long intervention, 6 weeks, 18 hours in total, but we can also shorten it into 4 weeks and 10 hours. We can also deliver this through an online platform. And so you don't have to travel to anywhere. You can be at the comfort of your own home or your own office to receive this. So in fact, I have written a proposal to MOH to request the funding to build something called Mindful Compassion Art-Based Therapy Virtual Community, to build an app and a platform that we can deliver these psychoeducation, deliver these interventions virtually and in a cost-effective, scalable, and accessible way. So hopefully that proposal will come through, and the intention is that everyone in Singapore can have access to that type of intervention.
Wow, all the best for that. Yeah, it sounds exciting. Yeah, so thanks. Another question that's coming through is that how often do you think we should have sessions to enable us to maintain the effects of MCAT for healthcare workers for the long term? So it's kind of related to the previous question, but I think it allows you to elaborate a bit more, Andy.
Right, sure. I think being able to, I think anything would help. I think even if it's just a one-off experiential, a 3-hour session or a 2-hour session, with an introduction of what this is and how we can engage in some of these practices would help. Obviously, a longer duration, a 4-week intervention or 6-week intervention would get the person to be more immersed and more knowledgeable and more able to incorporate some of these skill sets into their own life and their own professional practices. And so with both of the studies we've done with MCAT and MCAT dementia care, the intervention effect is sustainable, and it does last at least for another 4 weeks to 6 weeks. However, we do know that there would be significant drop after that time. And so what we could potentially consider is having booster session. So let's say we can set up a program whereby people in the institution are provided with the opportunity to attend a full 4 weeks or 6-week MCAT session. And then after they completed this, every month we offer a booster session. It could be a walk-in session. It could be a theme-based session. We can talk about grief today. We can talk about loss today. We can talk about burnt out today. And so it serves as a reminder and a refresher so that they can continue to engage in the practice that they do. For example, in LKC medicine, we do have a professor who offer regular mindfulness, like a half-an-hour mindfulness training virtually or in person in our medical school. So sessions like that could also be very helpful. I think even from a team perspective, if you're having a team meeting, if you really do believe that mindfulness practice is helpful, why don't we begin the team meeting with a short 2-minute mindful breathing activity? Right? So everybody's centered, everybody's here, there's a mind of clarity, and I can be completely immersed in that process of meeting. So simple activities and simple integration of practices can go a long way.
Yeah, thanks, Eddie. I just want to chime in at this point in time to actually echo what you're saying about incorporating these practices into our daily work. So I think we tried that out in both at 𝗕𝗂𝗶𝗃 Hospice and I think in Tan Tock Seng Palliative Medicine, where during Monday mornings, there's a handover of the weekend cases. And then after that, everybody busies themselves to run off to see patients. But I think we've done that. We've gotten staff who are more well-versed at mindfulness to actually lead these sessions and actually just have a 1 to 2 minute mindfulness exercise. And that really does wonders to refocus ourselves. So that's something that we've incorporated into our practice as well. The other thing that I really want to encourage teams out there to do and seriously consider Andy's recommendations is to perhaps build in regular sessions, perhaps once every 3 months or so. In 𝗕𝗂𝗁𝗃𝗪𝗓 and 𝗕𝗂𝒑 Hospice, with once every 3 months, we let the social workers or the art therapists and music therapists run the show, essentially. And we have a psychosocial round, or at 𝗕𝗂𝒑, they cheekily call it R21. But essentially these are sessions whereby we practice mindfulness. We have with art therapy, with music therapy, or things like that, to allow healthcare workers to process their emotions, as well as to come together as a team, to support each other and to share with each other and to be transparent to each other. Many times back in school, we all were. I didn't play sports, but for those who played sports or who did other things, I think part of the reasons why we enjoyed school is because we were part of teams. But sometimes when we come out to work, we forget that we're part of the team, and we just go about our work, and we do not spend enough time building the team together. And so I think that's something that I just want to share, and I just want to echo Andy's thoughts as well about that. Okay, we're running out of time, but I want to also give Andy some last word before we go over to Winnie. Okay, the last question, the toughest of them all. Asked by a very eminent psychiatrist within NHG. Andy, would you like to comment on the overlap between burnout, moral distress, post-traumatic disorder, and adjustment disorder?
Thank you, Aaron, for that important question. Sometimes these three things get mixed up in the literature and even now conceptualization of it. Burnt out by definition is the results of chronic, unresolved, prolonged stress. And that could lead to allostatic load. It can lead to allostatic overload. It could lead to sort of an overwhelming of emotion, mental exhaustion, as well as cynicism towards the work that you do. So it's related to stress, unresolved, chronic. Moral distress occurs when someone is asked to do something that is against their moral principle or against their professional code of conduct, such as a 90-year-old patient came in ICU, stage 4 cancer, comorbidities, dementia, end stage, and so on, and you know that you can't perform anything on him. You can't even do CPR, because if you do, that 5 cm compression can fracture his ribcage and it would do him more harm than good. But the family that comes in with him demands you to do this. If you don't do it, then I'm going to sue you and sue your entire institution. And then you feel pressured and you do something against your moral principle that leads to moral distress. And these two things can be compounded and integrated to cause even more duress for the physician. In terms of post-traumatic stress disorder, it can be a result of someone observing, witnessing, or experiencing vicarious trauma. So let's say, I'm in the ICU and someone's rolling in this figure dismembered, and that scenery is stuck into my mind for a long time and I can't get over it. It traumatizes me. Or I'm listening to someone's story, and through listening to that story, the trauma get vicariously imprinted onto me. And that could lead to a whole array of psychological symptoms, such as rumination, very similar to not being able to eat, not being able to sleep, physiological change, endocrine changes, and so on. So the three constructs are similar, but they are originating from different sources. And the impact that it has on the individual could also be different. And the way that we address them could also varies. Hopefully that has been helpful.
Yeah, thanks, Jared. No, I thought that was a great answer to a very, very difficult question and very multifaceted. Okay, I think we've run short of time. It's 2 o'clock, and I think I'll hand over time to Winnie to close the session. right? But thanks again, Andy.
Thank
Yeah.
you.
Thank you so much, both Andy and Mervyn, for today's sharing. I think we've learned so much, and something that touches us not just cognitively, really, but also the heart, right? Learning about the difference between empathy and compassion, for example, was very helpful for me. So thank you very much, both of you. Thank you for our participants. We hope that you had a good time. Thank you for staying with us. We just want to ask you, if you want to fill up for your CME points, then that's the QR code that's up there on the top, the brown one. That links you to the feedback form and the CME points. We do have another seminar coming up in November, and that's with Assistant Professor Michelle Chia, and she'll be talking about losses in illness narratives. And together we have with her Drs. Joanne Kwa and Joyce Yap from Jerry Medicine in Tan Tock Seng. So if you're interested in that, do then point your phone over at the blue QR code to keep yourselves on our mailing list, and we'll tell you when that next webinar is coming up. Right? So I'll just keep this slide here for the moment. And in the meantime, please allow me to thank Prof. Andy Ho as well as Dr. Mervyn Koh. Thank you both very, very much for joining us here today. Thank you.
Thanks. Yeah, bye.
Hey, have a good day.
Yeah, you
Have a
too.
good day,
Bye.
everyone.
All
Thank you.
right. Okay. Thank you.